Hello everyone and welcome to another high yield USMLE question. So this is going to be 60th question in the medical last question bank. So we have a HEME question today. So we have 45-year-old female patient with a history of chronic pancreatitis presented to the office with difficulty walking. So ataxia is going on. The patient also complains of mild fatigue and usual upper abdominal pain. So chronic pancreatitis have this epigastric pain because that's the region where you can get the pancreas pain. Like when you have pancreatitis, you have epigastric pain radiating into the back, and that's usually the pancreatitis pain here. So that's just her previous history of chronic pancreatitis that can explain the upper abdominal pain. Mild fatigue and the difficulty walking is the one that is now we have to explain why that is occurring in this patient with chronic pancreatitis. So prior medical history include recently diagnosed diabetes. Remember, that can also be because of the chronic pancreatitis. Remember, chronic pancreatitis eventually will affect the beta cells, right? So when the beta cells are destroyed because of the chronic pancreatitis, you can get diabetes because now you have no insulin because insulin is produced by the beta cells. Vitally, the patient is stable. BMI is low, and understandably, it is low because the patients with chronic pancreatitis have malabsorption. They do not absorb the nutrients. So that's why they will have low BMI. On examination, the patient is thin with pallor and has loss of fine touch with ataxia. So loss of fine touch and ataxia, pallor, these are significant findings. But what is going to help us here to know like which symptoms of this patient and signs to focus on is the neurologic here, which is going to be ataxia and loss of fine touch sensation. We have to explain why this is occurring. Now, the pallor can be explained by the CBC. So the CBC shown, which shows HB, which is low, which for females should be at least 12. So here it's 10 here. So which means that can explain the fatigue, that can explain the pallor in this patient. We have to know which type of anemia it is. So we have WBC is 6,000, which is fine. Platelet count is fine, which is 50,000. MCV is fine. It is normal MCV. And LDH is 400. That's elevated. So remember, whenever we are expecting a hemolytic anemia, LDH is usually raised because when the red blood cell lyses, they release LDH. So this is some sort of hemolytic anemia. So we have to now link these two things together and answer. So we have hemolytic anemia plus we have neurologic features. So which vitamin deficiency is causing that? So then they say deficiency of which of the following vitamins is responsible for this patient's presentation. So what causes hemolytic anemia plus neurologic features? And the fine touch is going to be the dorsal column medial lemniscal system, and that's exactly what's affected here. Dorsal column is affected, and also you may have spinocerebellar tract that is affected. So the answer is vitamin E. So remember, vitamin E causes hemolytic anemia, plus it causes neurologic symptoms because of the damaged demyelination of the posterior column, so the loss of fine touch, and also spinocerebellar tract. So both posterior column loss and spinocerebellar tract demyelination can cause ataxia. If it is posterior column, which is sensory ataxia, you will have a positive Romberg sign as well. So this is vitamin E. Now, another anemia given here in the options that can cause similar neurologic features will be the vitamin B12. So vitamin B12 and vitamin E have very similar neurologic features because both of them affect posterior column and the spinocerebellar tract. So the vitamin B12 also affect the corticospinal tract. So you may get the muscles involvement there as well. But usually the neurologic features you will not be able on a board question to differentiate vitamin B12 and vitamin E just purely based on the neurologic features because it's very similar. So how do you know then if it is B12 or vitamin E deficiency going on? So the first thing here they give in the CBC is that it's an hemolytic anemia. So obviously B12 is not going to be hemolytic. B12 is usually it's megaloblastic anemia, which means that MCV should be above 100. Here it's not above 100. It's hemolysis going on here. So it's going to be vitamin E here. So also other differences between vitamin E and B12 is that B12 will have hypersegmented neutrophils. B12 will also have B12 will have increased methylmalonic acid as well. So these are the differences that you can see between these two. Right, so another clue to vitamin E deficiency in this patient is that the patient has chronic pancreatitis. So whenever you have chronic pancreatitis, it could be because of recurrent acute pancreatitis from alcohol. For example, if someone is alcoholic, they can get recurrent pancreatitis and they can cause chronic pancreatitis. So that could be one thing. And for chronic pancreatitis, due to any etiology, it can cause fat-soluble vitamin deficiency. These include A, D, E, K. So that's another clue that it's vitamin E, right? Because chronic pancreatitis patients will have fat-soluble vitamin deficiencies. Now, so this is what I've written here, that vitamin E is similar neurologic feature as B12. Versus B12, we have no megaloblastic anemia here in vitamin E, no hypersegmented neutrophils, no raised methylmalonic acid. So let's run through the options here. We have vitamin D is going to be the wrong answer. Vitamin D usually would cause rickets if it's kids. And it's going to cause osteomalacia if you're an adult. It's going to cause weak bones. It does not explain the fine touch here in the anemia. B3 is the one, niacin. Patients with chronic pancreatitis, they're not at risk. B3, niacin is usually going to be, just remember three things here, risk factors. One is carcinoid syndrome, one is isoniazid use, one is if you have a corn diet, a staple corn diet, because corn is deficient in niacin. And also heart nerve disease. So in heart nerve, you lose tryptophan. Tryptophan is required for niacin synthesis. You lose it in the urine. So a heart nerve, also carcinoid, because carcinoid produces a lot of serotonin. Serotonin requires tryptophan. So all the tryptophan is shunted towards serotonin synthesis, and you have less tryptophan required for the niacin. So you get the B3 deficiency. That's going to be pellagra, the 3Ds. So you will have a rash, you will have diarrhea, dermatitis, which is the rash, diarrhea, and dementia. And then with the B12 we discussed extensively, so we can skip that. And vitamin E is the answer, which we discussed here. This is the answer. And then we have B9, which is folate. It's going to also be hypersegmented neutrophils. You can get megaloblastic anemia, but no raised methylmalonic acids. It's not going to cause neurologic features, so wrong answer. Vitamin A can occur in chronic pancreatitis because it's also vitamin D. It's also fat-soluble vitamin, so just like vitamin D. So vitamin A is going to cause night blindness, it's going to cause B-dot spot as well. It's required for specialized epithelial cell differentiations. That's commonly tested on step 1. So remember, this question is going to be asked on both step 1 and step 2. I've seen more on step 1 because vitamins are very high yield for step 1. So expect at least 2 to 3 questions on your exam day. So, but it can easily be asked on step 2 as well. So this is for both step 1 and step 2. All right. So if anyone requires tutoring, they can email me here. Comp tutoring, med school exams like NBME exams tutoring, USMLE tutoring. If anyone requires, they can just email me here. And thank you for watching. See you in the next video.